Hey peeps, welcome back to one of the GYO surgery series. This one is on bowel resections. I have a lot of pictures in here and I actually don't reference any of them, but I don't own any of them. And this is for educational purposes only, no medical advice. Okay, so we're going to start by going over the stapler types. We'll go over a GIA, a TA, and an EEA. We're not going to cover the contour, but if you have questions about that, let me know. We could always come back to it. We'll start with the GIA, gastrointestinal anastomosis stapler. So as you can see in this picture, it lays 2 rows of staples and it also cuts. So here's your rows and then it cuts. And within these rows, you have several staggered lines of staples, so 2 or 3 kind of in each side. These are able to reload, so this green part, this blue part comes out and you can load it again, which is nice from a cost perspective. And they come in different lengths. So this one here that you can see is a GIA 80. It also comes in a 60 and 100, so you can see maybe here there's an 8. If you're working with a different company, some of them have, they actually come in 55, 75, 100 instead of 60, 80, 100. So just know whatever company you have. And then the staple leg length is the depth of the staple. So if this is your staple, then this is the leg length here. We'll go over more of that on this next slide. So the stapler types are based on the leg length, and once again, leg length of the staple. White is typically your vascular load. Blue is our standard load. We typically use this for our small bowel sections. And then you have gold, which is similar but thicker, and green. And this is all based on the leg length. And as you can see in this chart here, you have an open staple depth, but then you also have a closed staple depth or height. And that is because when you fire the stapler, it, like most staples, becomes a little B-shaped. And so that's not really equal on both sides, so forgive me for that, but you actually get a decrease in the height or depth of the staple. So you have to keep that in mind when you're choosing your stapler. And it works just like this picture here. So it comes disarticulated. You'll put one side on one side of the bowel, and then you'll click this in, and typically you'll try, there's a little part here you'll click in, and then close. You'll kind of arrange your bowel, and then there's a lever that you push forward, pull back, and then a button on the end of it that you click to open. Our second stapler type is a TA, or a thoracoabdominal. This is will be a straight line, and this one doesn't cut automatically. So let's use this as an example here. You put it across your bowel, you pull a trigger at the end of it to fire, and then you are essentially holding it while someone either uses a knife or Mayo's Mets to cut across here. It lays down a double row of staples, but you're cutting it, and then it ends up like this. So this is typically used to close something because it doesn't cut. It also comes in different cartridge lengths, 30, 45, 60, 90, and then there are 2 sizes, blue and green. One typically used for small bowel, one for large bowel. Next, we have our EEA, or our end-to-end anastomosis stapler. This will lay a circular double staggered row of titanium staples. And so, nice picture here. Say you use your GIA to cut across your sigmoid, your rectosigmoid area, then you open this section. You'll typically put a purse string suture around here, either hand purse string or there are the automatic purse stringers. You'll place this anvil, which you can see here, it comes off, into the one side. The EEA goes through the anus and up the rectum. So this is kind of the EEA. And then it'll connect to the anvil. You will turn the knob at the end, and then it'll articulate together. This firing device is what kind of fires the staples, and then you'll turn the knob the opposite direction 2 times to release, and you'll gently pull out. when you pull it out, you'll see this tissue that is around here will be on the anvil, hopefully intact, and hopefully you'll have 2 of them from each side, and that's what we call the donut, and you send those to pathology to make sure that they're intact. The EEA comes in several diameters from 21 to 33. Usually a 28 or 29 is the most common, depending on what device you're using or what company you're using. And just know that you lose about 1 centimeter of the bowel when you're connecting the tissue together. So you have to take that into account when you're trying to decide, do I have enough space to reanastomose? Is this going to be on tension? You'll lose 1 centimeter, so keep that in mind. Speaking of repairing or resecting bowel, when is it best to resect the bowel? So if your bowel injury is greater than 50% of the diameter of the bowel, if you have a through and through trocar injury or a thermal injury, you're really going to want to consider resecting the bowel. So for a thermal injury, I just have a note here that if it's a very small, like bovie onto the bowel, you can consider oversewing this area. Thermal injury, the textbook answer is going to be that you resect the bowel because we don't know about thermal spread, and most likely you're going to resect it with a nice wide margin due to this issue of lateral thermal spread. If you're considering repairing an enterotomy, we often will do a 2-layer closure. One nice way to remember how to throw your sutures is a suture line goes the way the poop flows, or so the way the flow goes, someone said to me. So in the way of the flow, something like that. And so the reason for that is if you imagine that even if your incision is, parallel to the bowel, if you throw your suture like this, you're at risk of stricturing or narrowing the bowel. And so you always want to go the way the poop goes. For these, you can use 3/0 Vicryl or 3/0 Silk. And typically you'll imbricate the second layer with what we call the Lembert's stitch, which is a kind of imbricating stitch where you take a nice wide bite, come out, come up, come out, and then that tissue will come together. Going back to when you're thinking about doing an anastomosis versus doing a diverting ostomy, we're oftentimes thinking about this. Let's just use the example of a rectosigmoid resection, and you want to really weigh the risks and the benefits of leaving the anastomosis or diverting the patient, or even doing an end colostomy. They're not always the decision is diverting ostomy, because as we'll discuss a little bit later, a diverting ostomy doesn't necessarily decrease the risk of an anastomotic leak, but it decreases the overall morbidity of if there is a leak. And so, but risks associated with the anastomotic leaks: older age, a low albumin, 1 or more small bowel resections in the surgery, a manual or hand-sewn anastomosis, and then short distance from the anal verge. Other risks that you'd want to consider is previous radiation, diabetes. Both of these have to do with wound healing, and then a lengthy surgical duration. The presentation gets more basic as we go along, but just to clarify this for everyone, an ileostomy versus a colostomy, it's pretty self-explanatory, but it is where you make your ostomy on the bowel. So this is a nice picture. You can also have a jejunostomy, an ileostomy. These are both small bowel, and then you can also have a colostomy in the ascending, transverse, or descending. Most commonly, I would say transverse if you're going to do a loop. Oftentimes, if you're going to do an end, it's the descending or sigmoid. And then your output is going to be very different between an ileostomy or a colostomy. Ileostomy average output is on the higher side, and that is actually one of the number one complication of an ileostomy is high output, leading to dehydration and electrolyte derangements. The consistency is liquid to semi-liquid, as opposed to a colostomy, where the colon is absorbing all that water. You're going to have a more formed or semi-formed bowel movement. Colostomies put out much less stool per day, and the most common complication is skin irritation. These, like I said, more basic as we go along, but these are just examples of end versus loop colostomies. So when you're bringing up an end, it's the literal end of the bowel, and then a loop is bringing up a literal loop of bowel. So just to be sure that we not making any assumptions of what people know or should know. Okay, so this is going back to the technical side of bowel surgery, but there are two really great papers, the American Society of Colorectal Surgeons, Clinical Practice Guidelines, and then also some technical considerations in stoma creation. I will link both of those in the notes, but they basically just go over some technical considerations on making ostomies and, kind of how do the experts do it. And so they recommend a 2.5 centimeter circular skin disc. Then when you're kind of getting the subcutaneous tissue away, they recommend that you don't core out the tissue, don't bovie out all the fat. Make a 3 centimeter vertical incision, then 1 centimeter perpendicularly. And then you push the bowel through the anterior abdominal wall as opposed to pulling it, kind of like we saw in the last picture. If you look back, they're pulling the bowel through, but we'll give them the benefit of the doubt. Maybe they're pushing it as well. And then how much of the ostomy needs to be protruding past the skin level? This actually is different in multiple different sources of literature. But in general, colostomy needs to protrude less than an ileostomy. So 1 to 2 centimeters is what they're recommending in these papers for a colostomy, and then an ileostomy is anywhere from 2 to 5 centimeters protruding. So this is just another technical point that they made is, so colostomies, when you're maturing an ostomy, which is basically once you pull it up, say you closed your incision and then you need to mature the ostomy. For ileostomies, you'll typically evert and kind of make that rosebud, that nice rosebud. Colostomies, you don't necessarily have to evert them, but you can. And so they can just kind of be flush with the skin or everted. And so with the colostomy, you'll want to take a full thickness bite of the terminal end of the bowel and then followed by a dermis bite. So here they're kind of getting a little bit of the epidermis, and basically these papers are saying to avoid the epidermis, to avoid mucosal islands in the skin for better wound healing. And then ileostomies, you get that nice rose budding. We'll actually see on the next page a loop ileostomy photo, but you'll do sutures in triplicate. So you're going to get a full thickness dermal bite, or a full thickness bowel bite, and then you'll get a seromuscular bite of the bowel kind of down lower like they do here, and then dermis. So, and that kind of helps you evert the bowel, like this nice rosebud pattern here. As we mentioned earlier, diverting loop ileostomies, making a diverting loop doesn't decrease the incidence of an anastomotic leak, but instead it decreases the related morbidity if there was to be a leak. You want to make these 20 centimeters from the ileocecal junction, especially, if you're thinking of reversal, you need to have enough space in order to reverse. Technically, the fascial incision is only a 2 centimeter by 1 centimeter when you're making this ostomy. And once you pull it up and you're ready to transect the loop, you want to transect about 80% circumference of the bowel on the anti-mesenteric portion of the bowel. Some people will place like a red rubber or a bridge or a rod, and that can be removed after 5 days. So that is one of the longer videos on here, however, chock full of information. Please let me know if you have any questions, if there's something that we didn't cover. Would love to hear any kind of feedback. But otherwise, I hope you learned something and have a great day.